Hello, everyone, and welcome. We are now over the halfway point on our geriatric healthcare lecture series. This is week 6, and my name is Barbara Cochran. I'm the Associate Director for the Northwest Geriatrics Workforce Enhancement Center. Our mission is to focus and optimize primary care of older adults. And in particular, that involves a vision of engaging families, caregivers, age and dementia-friendly health systems, primary care providers and their communities to support older adult health and well-being. And one of our objectives includes transforming clinical environments to be integrated age-friendly systems. And I mention that because that's a big focus of our geriatric healthcare series, and particularly the fact that these systems should be practicing the 4 M's with every encounter with their patients. And the 4 M's include what matters. In other words, what's important, what are the preferences for the patient. Medications, making sure that all medications are necessary and that they don't interfere with mobility, mentation. Another one of the 4 M's is mentation to prevent, identify, treat, and manage dementia, depression, and delirium across the various settings of care. And then, of course, mobility to ensure that older adults move safely every day in order to maintain function so that they can do what matters in their lives. This is our lecture series schedule for the winter, and you can see that we're at the non-pharmacologic pain control. So I'll just sort of link that to the 4 M's a little bit and say non-pharmacological pain control, and I'm sure Dr. Sturgeon's lecture will address various aspects of these 4 M's because they're very critical for pain control. Next week, there's actually going to be a shift in that we've had to do a little bit of scheduling readjustment. So just to let you know that the Women's Health lecture is going to be next week, and the Aging Eye lecture will be on March 3rd in place of the Women's Health lecture. Logistics for the Geri series are that either I or Dr. Vitiello will be on site during these presentations, and we're monitoring the Zoom chat. During the lectures, we're kind of really looking for you to let us know if you're having any technical issues, but during the last 15 minutes or so, we'll open up the chat and you can ask questions of the speaker, and I'll go ahead and read those so that they get addressed effectively. If you could put your questions into the chat, that would be great. Just a reminder that you should be completing 1 profile form for the winter series. For each lecture attended, particularly if you're interested in continuing education credits, a sign-in or attendance form is needed. And then we would really appreciate if you would complete an evaluation form for each lecture you attend. You should check with your site coordinator as to how you access these, whether they're on paper copy or there are SurveyMonkey links, depending on your site. Another thing to remind you about is that you can get up to 15 hours of continuing education contact hours from both the UW Continuing Nursing Education, which covers social work counselors, psychologists, and other professionals, as well as the American Academy of Family Physicians for CME credits. The recordings are posted online on our Northwest GWEC website, nwgwec.org, within about 48 hours of when they are presented live. And when you go there to check out or revisit the lecture for this week, please feel free to go and take a look at the over 90 archived lectures that we have from past series that are posted there. They're available for free. The only thing to keep in mind is that if you watch them on the website, there's no continuing education contact hours available, but you can go to the UWCNE website and sign up for past lecture series and get continuing education contact hours that way for a small fee. Today, I'm going to introduce Dr. John Drew Sturgeon. He is an acting assistant professor in the Department of Anesthesiology and Pain Medicine at the UW School of Medicine. He's a fellowship-trained licensed pain psychologist with specialized training in cognitive behavioral therapy, as well as experience in other psychotherapeutic approaches for people with a wide variety of chronic pain conditions. And he has a particular interest in the roles of positive emotions and social relationships and how these factors promote better function and overall quality of life in people with chronic pain. So a great expert for giving you content in this area. Welcome.
Thank you, Barbara. Hopefully everybody can hear me. Clip it here. So it was a very kind introduction. I'm Drew Sturgeon. I'm a psychologist. I work at the Roosevelt Pain Clinic just here in the U District. Just let me know if people can't hear me. I have no disclosures that are relevant here. I'm a scientific advisory board member for an online social-based intervention for chronic pain, TribeRx. It shouldn't be relevant to anything that we're talking about today. So just to begin, an area of increasing interest for both clinical care and research is chronic pain in older adults. It has historically been a little bit understudied, but by 2050, estimates suggest that about a fifth of the US population will be over the age of 65. And so despite the fact that medical interventions have gotten better and better at increasing longevity and addressing medical problems, there hasn't been the same degree of progress in improving pain or disability or quality of life, even if people are surviving longer. So you can see here that the older people get, the more that they actually, the higher the prevalence of chronic pain. So in younger adults here, younger adults meaning anybody under the age of 65, we roughly estimate it's about 15 to 20% of people who have chronic pain. Chronic pain here again being defined as pain lasting longer than 3 to 6 months. And for those who maybe aren't aware of that sort of designation, the idea is we usually affix that label because that refers to the amount of time that you can expect tissue to still be healing if there's some sort of an initial injury. So once we're outside of that 6-month window, we're usually kind of confident that what this is a chronic pain condition. And then once you get into older adulthood, the prevalence essentially doubles. And for those that maybe are residing in nursing homes with higher care, there's been some estimates as high as 80% of people in nursing home settings have some degree of chronic pain that's ongoing. I'm not sure how well this comes up on the screens here, but you can see there's kind of a breakdown. This is a great paper from just last year on all the different areas where people can have chronic pain. Joint pain is the most common. Neck pain, back pain in general across adults tends to be the most prominent, but in older adults, you can see these other areas are problematic as well. So when it comes to pain assessment in older adults, the research tells us that it's kind of inconsistent. So this can be both for patient-specific reasons as well as provider reasons. So there's been some research historically saying that older adults tend to be a little more stoic. So they present to appointments and they may actually be experiencing a considerable amount of pain, but don't really end up talking about it. And that maybe is something of a social convention. I was taught not to complain even when I go to the doctor. Some of them actually, and we still routinely hear this, that older adults sometimes have this assumption that pain is just part of aging. Well, I'm getting older, so things are hurting more. I'm not really sure that warrants a discussion with my doctor. And then in some cases, certainly when there's more cognitive impairment on board, it's not that people won't talk about pain, it's that they maybe don't remember or that they can't talk about it as effectively. But this is not all on the patients. It turns out that providers also don't reliably assess chronic pain in older adults the way they might in younger adults, for some of the same reasons. This idea being that, well, you're getting older, of course, there are going to be some aches and pains, but also when you've got a patient coming in who's an older adult, they do tend to also have a higher likelihood of comorbid medical problems. So pain itself may not be the primary focus of a visit for somebody who's 70, the way it would for somebody who comes in at 25 or 30 and saying, my back hurts. Along the same lines, you may get a subset of patients who come in and are really motivated saying, you know, I can't work right now because my back hurts, because of my knees, because of my headaches. But in older adults, that return to work may not be high on the priority list. So there's sort of this idea that rehabilitation takes a different look, and you may have an orientation towards longer term management that looks different in older adults than in younger adults. So the idea here is that it's something of a moving target. I don't know that there's really necessarily an established standard for this, but they are things to be aware of if you're working with older adults with chronic pain. So one of the things that's important to know broadly across primary care, chronic pain is among the most prominent symptoms that bring people in. Chronic low back pain actually is the most common and the most costly medical symptom in the United States. And unfortunately, primary care providers often report that working with people with chronic pain is really hard. There aren't really clear guidelines for how to treat them. There's a lot of limited training. So people with internal medicine or family medicine training, they may not have gotten a lot of training. I think historically there's even been a soundbite that veterinarians get more pain training than human physicians do. So hopefully that's changing. But as of right now, the sort of workforce in general, the providers out in the community often say that it's hard because it requires multidisciplinary care. We're not really trained in it. We don't really know what to do about it. If a patient comes in and says, I have this pain problem, the next steps are not always terribly clear. And so the other part is, because it's such a difficult problem, providers sometimes shy away from managing these patients longer term. And this is especially true in the context of the opioid crisis that we now have. So even though there's actually quite limited evidence for long-term benefit for opioid therapy in chronic pain, and incidentally, that's true regardless of whether or not it's older adults or younger adults, this is still very much what patients have historically come to expect when they come in to see the doctor for pain. So even though pharmacotherapy itself is a valuable component, and don't get me wrong, it is. So you'll notice, incidentally, that this figure that I have on the screen right now is from an article on pain management in children, but I liked it so much I decided it was worth mentioning anyway and qualifying. This is very much the same idea of how pain management works, that it's highly multidisciplinary, it's highly integrative. And so medication, pharmacotherapy is part of that. But if we rely just on that, the likely benefit in the long run is going to be limited. And this is especially true as adults get older, because even if they've been taking a medication for years and years and years, they may metabolize that medication differently in older age. There may be increased risk of falls or cognitive impairment that weren't there before. So there's sort of a moving target here as well. Even with pharmacotherapy, which is valuable, it is not a panacea. And it's something that continues to need to be monitored and adjusted. So the takeaway here is simply that in order to manage chronic pain effectively, it does involve a need for a lot of multidisciplinary approaches. And so the caveat as I move through the rest of this talk is, because I'm a pain psychologist, there's a little bit of hammer-nail syndrome here. I know more about psychology, so I'm going to talk about the psychology of pain longer, but I want you to know, just because I spend less time in the other aspects does not mean they're less important. It's just that I know less about them. So rather than waste your time pretending that I know all about these things, I'll give you a high-level view of the research, and I'll talk more about what I actually know. So right at the top of the list, and this is where I think it should reside, and I even saw this in your earlier slide, physiotherapy, exercise-based therapies are among the best for pain management. And this includes both seeing a physical therapist for something like exercise training, but also at sort of a community health level or at a primary care level. It also involves encouraging patients to be more active day to day. It doesn't have to involve going to see a physical therapist for 10 or 12 sessions. This is about getting people to mobilize in ways that maybe are sustainable for them, knowing that movement is one of the best ways we have to treat chronic pain across the lifespan. Now, when we look at, and by the way, all the results that are listed up here all refer to meta-analyses. So these are large-scale syntheses of other clinical studies. And the truth is, all clinical research is a little bit flawed in the sense that they're often low-quality studies, small numbers of patients. But in general, these are pretty robust, especially the ones toward the top. Physiotherapy has got there's a lot of studies on how physical therapy can improve chronic pain. And the effects in general, and it kind of depends on the pain condition you're looking at, but they do tend to have pretty reliable effects on both pain and self-rated disability, as well as some maybe less consistent benefit for things that are psychological in nature, so quality of life, mood. But like I said, there are issues with a lot of clinical trials where we look at effects right after people finish therapy, and we don't look necessarily longer term whether those things get sustained. And that, by the way, is the caveat for all of these interventions. Long term, we don't have good evidence for anything for chronic pain treatment. So we know what works in the immediate term. And in the longer term, it probably boils down to what's sustainable for the patient. So along those same lines, yoga, which here refers to typically sort of modulated breathing and slow guided movement, has pretty strong effects on pain and disability. But again, the quality of the evidence is not quite as high as we'd like it to be. It does have the benefit of being much more accessible in the community. but also with the caveat that for those who are doing a lot of work with people with chronic pain, patients will sometimes come in and say, you know, I tried this yoga, it really flared me up. So there is variability even in the sort of quality of what's provided, and the acceptability of it for every person with chronic pain may be a little bit different. Acupuncture, there's a lot of research on this. The effects in general tend to be a bit smaller, but the benefit is that it seems to manifest across a lot of different chronic pain conditions. So this is true for back pain and neck pain and arthritis pain. It also works for more centralized forms of pain, like migraines. So this is yet again another valuable intervention to consider for those that, and one of our colleagues in the pain clinic, Dr. Tick, likes to talk about how even in places where you may have trainees or there's sort of Eastern medicine type schools, sometimes you can get low cost acupuncture and community services that can be a nice option for patients that are low income. TENS units, so transelectrical stimulation, does seem to have a benefit, but the quality of the evidence is low. And so essentially what this seems to boil down to at this point is TENS is a really nice thing to add for patients who are already becoming more physically active. Where the benefit seems to be the most clear is when people are exercising. TENS can help them tolerate it better, and it seems to be allow them to move a little bit better with less pain. Spinal manipulation, so things like chiropractic services here, manipulation therapies, manual therapies, I think is the term they prefer. There is good evidence for short-term pain relief and function. This is primarily in chronic low back pain, but it's not really clear whether or not these things translate to longer-term effects for things like return to work. And by the way, I should also mention here, these studies are primarily across the age range. We don't have really good evidence for specifically these non-pharmacological approaches in older adults. We'd like to have that, but you can safely assume that with most of these interventions, whatever the body of evidence it is for younger adults, it's smaller in older adults. This has been an area where it's been less rigorously studied. And so other CAM treatments, other complementary and alternative treatments do have some evidence, but in general, the quality of the evidence is low. We don't really have enough to confidently say whether or not anything else works the way we'd want it to. And so you'll see I buried the lead here. We're going to talk more about psychological mind-body therapies. So the bottom of the list, not because I think it's the least important, but because I'm going to spend a whole bunch of other slides talking about it. So I want to bring your attention to one study that was done in JAMA Internal Medicine just a couple of years ago, where they actually did a meta-analysis of psychological interventions for pain management in older adults. So this was about 2,600 people across 22 studies. It was primarily musculoskeletal pain, so back pain, neck pain, arthritis pain, and then there were a few others with things like rheumatoid arthritis, but primarily it was the sort of pain you most commonly see in a primary care setting. And it included all sorts of different psychological approaches, CBT, mindfulness-based therapies, acceptance commitment therapy. We'll talk about all those a little bit later, but they sort of lumped them together. And for our purposes here, it's probably appropriate to do that. In general, what psychological approaches show is a pretty robust but small effect on a variety of things relevant to chronic pain, like the intensity of pain itself. So typically we're looking at about a half point to a point when this is done as a freestanding intervention, as well as things like the degree to which pain interferes with function, your physical function overall, your mood, how healthy you kind of rate yourself to be, and then coping variables, things like your confidence in your ability to manage pain independently, or the degree to which you view your pain in a catastrophic manner. Obviously, the second one is negative, the first one is positive. And the thing is, ultimately, what we've seen from a study like this is the effects are more or less the same as they are in younger adults. So even with a larger degree of evidence, we're pretty confident this is about where psychological approaches land. The nice thing about these sorts of interventions is that by and large, there aren't a whole lot of side effects. Now, it can be hard to access services, but patients don't usually come out saying, I have significant side effects from this. It didn't really pull me away from doing anything else I wanted to do. And it can be enhanced using things like social support, especially for those that are maybe nursing home dwelling or patients that may need more help from sort of a memory standpoint. And it also can be used in a more focal way in combination with something like physical therapy. That's actually where our evidence is the best. Now, again, as we say that means you have a medical provider, a physical therapist, and a psychologist all on board. That is unfortunately not that common in the community, but it is still where the evidence suggests the strongest effects. So, knowing that the focus here is primary care, I thought I'd take a step back and talk a little bit more about how psychology works in primary care. So in general, there is a variety of setups within this area, but in essence, you have a lot of primary care offices that are beginning to use psychology, and this psychology here may involve a psychologist in clinic, but it also may involve clinical social workers, many of whom have some of the same training that we're talking about here. And so sometimes they're co-located, they actually are based in the same clinic, and sometimes they're in nearby offices. So they may not be in the clinic per se, in the provider room, but there may be another place nearby where you can bring somebody in quickly for patients who may seem to benefit from behavioral health. So what the research broadly seems to suggest is that there is a specific impact of psychology in the primary care setting, and this is not specific to chronic pain, so your clinical outcomes here may include pain and function. It may also include other things like mood. It also tends to leave patients and providers feeling more satisfied with the interactions. Providers here not being the mental health providers, being the medical providers. Patients do seem to be able to adhere to their medication regimens a bit better, and this is especially true for things like, for conditions where there's a heavy degree of self-management that's needed, things like diabetes or hypertension. Along the same lines, one of the things that a psychologist in a primary care setting is likely to focus a lot on is health behavior. So helping patients eat better, or adhere to a diet plan, or an exercise plan, or quit smoking. So there can be sort of multiple targets that are hit when you have a mental health provider in primary care. And so where this often is one of the things that's been kind of a nice selling point for large healthcare organizations is when you bring mental health providers into the primary care setting, it can sometimes reduce medical utilization among your high resource users. So the hope is that if you can kind of bring that distress from them down, they may stop calling the clinic every 2 days or coming in for regular appointments where nothing's really meaningfully changed yet. Now, again, like everything else, you can take some of this with a grain of salt. There's still more work to be done on this, but to this point, it does seem to be a pretty promising direction when and if you are able to bring those services into a clinical setting. So the way this works for pain management is that initially the primary point of contact is still the primary care provider. So they answer specific questions as much as they can about what the pain is, what it's caused by, and ideally, and this is something I stress a lot to my colleagues in the pain clinic, there's nobody else involved in the patient's care that they're going to go to and ask more about why am I having pain than the primary care provider. So to whatever extent we can answer that question first, it makes it a lot easier to ask them to self-manage. The other thing that's gotten some positive press recently is the idea that you can actually, as a primary care provider, use some approaches like motivational interviewing, where you are actually helping patients work through some ambivalence around behavior change, and actually can help them improve the likelihood that they'll respond or even accept a referral to mental health. From there, you usually get a psychologist coming in to do a brief psychosocial assessment, which may or may not have been covered as much in the context of a primary care visit. So figuring out essentially what the patient's having difficulty with and what they may benefit from the most. So sometimes it's as simple as bringing somebody in and teaching them a few basic stress management strategies. But for many of our patients that are more complex, and everybody on the community that's listening right now, I'm sure has got those people in mind, there can be longer term involvement with mental health care as well. So this is the idea of sort of being a graded approach as much as we can make it that way. So just to talk a little bit more broadly, and I try not to have just a whole block of text-heavy slides, but sometimes it's unavoidable. So hopefully the picture helps. The early models of chronic pain, or the early models of pain in general, sort of started with Melzack and Wall in the early 1960s. This idea of the gate control theory of pain, that when you sustain an injury, the nerves pick up that site of damage, that nociceptive signal. It's transmitted from, say, your twisted ankle through your peripheral nervous system, through the spinal cord, and into the brain. And it's there that pain occurs. So the message is, pain is always in the brain. That's the only place it can occur. And so the dorsal horn of the spinal cord historically has been a big point of focus, where it sort of acts like a gating mechanism. So if you close that gate, some of that nociceptive signal doesn't travel through, people get less pain. If the gate is open, there can be more nociceptive signal being processed by the brain, and it increases pain. Now, it turns out this is a little bit of a limited model. In the long run, what we've just discovered is not a one-way path from the site of injury to the brain. It's actually a constant two-way communication between the brain and the body. But this was a nice model, and it's still one we use when we explain pain to patients. So helping them understand that just because the damage is there, you're not going to feel pain exactly the same every moment of every day. right? There's all sorts of examples of this. So if I bang my shin and then rub it and it feels a little bit better, I haven't changed the damage in my leg. What I did was sending a competing non-pain signal that crowds that out. So I get a little bit less pain. Heat works the same way. TENS units work the same way. For those that are really involved, things like spinal cord stimulators work the same way. But also medications. If you take a medication, by and large, you are not fixing the injury that caused pain. What you're doing is changing the brain's response to it. And so this is this idea that what you're really doing is changing how the brain responds to the signals coming from the body. And so more recent models sort of suggest that it's not just what we're getting from the body, but rather the brain itself changes, especially if we've had these pain inputs for a longer period of time. So sometimes with patients, we use the term a well-worn pain pathway. If I've had back problems for 10 years, my brain is really used to getting these threatening signals from my back. And across time, it almost evolves to come to expect those. So even if we sort of fix some of that structural problem, that pain may continue if we don't also work on the brain. And so the narrative here, the example, the analogy we might give here is something like phantom limb pain, right? You can't have nerve input in a limb you no longer have, but your brain still has a representation of that part of the body. And because it's already been threatened, the brain continues to protect it until you find a way to treat it. And incidentally, for those who are curious, that's where the neuroscience and where a lot of the work in phantom limb pain is going, is mirror therapy. So you're showing the brain that the body is safe in a way that it didn't know. So this is kind of a nice selling point for us, where we're saying, look, your pain signal can be changed not just by what's happening physically in your tissues, although those certainly matter, but also that if we treat the brain itself, your pain signals can go down. So broadly, for those who've kind of maybe are a little less initiated with this area, it's kind of nice to be able to review with patients what chronic pain is. So first and foremost, we talk about pain as being more than just a sensory signal. That in addition to that feeling of a burning pain or a mechanical pain when I twist my ankle, that there's also an emotional and a cognitive component to all pain. So we are hard-coded to respond to pain with a fear or negative emotional response, because that's what keeps us safe in the acute case. If I break my leg, I should be afraid of that. I shouldn't wander into the middle of a campfire and stand there and look at it and go, this is interesting. I should get out of the fire. And so along that same line, pain is a very effective teacher. So then the story I tell with most of my patients is, if you were a child, and you put your hand on a hot stove, if you were like most kids, you never did that again. You learned once, this is not the right thing for me to do to keep my body safe. So in the acute case, that's useful. But in the chronic case, where the pain may or may not be signaling ongoing tissue problems, that learned response can actually be counterproductive. It's a good idea to not walk on a broken leg, but if I have leg pain that occurs for 5 years after my injury and there's not evidence of ongoing tissue change, should I just continue to avoid walking? Is that likely to help? The answer is typically not, and we'll talk about that in a little bit. So we talk about pain here being sort of a teaching response or a protective response by the brain. Your brain picks up when your body's in danger and it tries to protect you. So if it hurts, I stay off of it until it heals. If it's already healed and it still hurts, now we have to do something different. So this is where the psychosocial model comes in. So this is one that's gotten popular. This is a model that's been sort of research-based in chronic pain over the last 20 years. And it's the idea of fear avoidance. This is kind of what I was talking about before. Once you have a pain problem that is beyond the acute phase, and again, the acute phase here, if you injure yourself, if you're recovering from surgery, you have an indication not to move, you don't move until the body heals. But once you're past that period of time, what tends to be true is that those otherwise protective emotional responses become less protective. So pain can produce sort of a fear of pain. So every time I sit or every time I walk or every time I bend or lift, it hurts. So I start to avoid it. I start to view pain as a more catastrophic experience. And then there can even be this idea that because my pain hasn't gone away, I must actually be damaging my body further. And that can be a huge point of contention for our patients. If we're asking them to be physically active, but they're not convinced they can do so safely, you're not likely to get very far in getting them to exercise. The problem is, once these things are in place, it actually reinforces avoidance. So if I'm afraid of pain and I keep experiencing pain when I do something, I'm not going to do that thing. And the basic model here is, if we don't do something that hurts, we usually end up making that problem worse. I get sensitized to the thing that I should be able to do. If I haven't run in a year. If I wait a year and then try and go running again, it's going to hurt more regardless of whether or not I have chronic pain. But in the chronic pain case, it's sort of like the amp is turned up. This is sort of an amplified effect. And so once you've got people who are avoiding more, they get weaker, they get deconditioned, balance becomes a problem, and then pain gets worse, and then it just fuels this whole process further. So what we need to do is to, you can see on the right side here, confront that fear, work through sort of structured ways of helping pain and fear come down, and then in the long run, it can actually help people move more effectively, be less fearful, and have less pain. So this is a recently published model on the psychosocial model for chronic pain in older adults. So biopsychosocial here is what we've kind of come to explain our most modern treatment models. So it involves things like the structural problems that are happening in your body, but also things like other medical comorbidities, sleep disturbance. You may have genetic or biological factors that are at work. There's also psychological factors like I've been mentioning here, catastrophizing avoidance, depression, anxiety, stress, and then things that are kind of higher or broader structures, things like race and ethnicity. There is some evidence, for example, that patients of Black or African American descent are treated differently in a chronic pain context than those that are white. Culture is much the same idea, both from a communicative standpoint as well as willingness to utilize certain services. Socioeconomic status, especially among those who are impoverished. There are not the same degree of other resources available for pain management. And then those that maybe are a little more specific to older adults. Things like ageism, things like an expectation that you maybe won't get better, or limited support. We know that isolation itself is a huge risk factor for chronic pain, for mental health problems, and that problem can become exacerbated in older adults, especially as they move away from, say, a working environment, or as friends and family start to pass away. And so the outcomes here you can see kind of tie back to what we've been talking about, which are physical function, cognitive function, and quality of life. I would probably put pain in there too, but that's a point for debate. I guess that's right in the center of the model. So the remainder of our slides, we'll talk a little bit more about the specific psychological approaches for chronic pain. And it's important to know that these things are not usually mutually exclusive, that these things can often be used together. But what I wanted to do, because pain psychology is something of a small field right now, I thought I'd give as much of an overview as I can. And I was cautioned not to be overly technical, and psychologists like to make up words, so I'll try and avoid that whenever I can. So the most common, and we'll talk about these each one by one, this includes things like cognitive behavioral therapy, pain self-management, which is sort of an offshoot of that, mindfulness therapies, acceptance commitment therapy, graded exposure, hypnosis, and then some emotion-focused approaches that are getting traction recently. So CBT is what we call a pain coping skills toolbox. And then just from a broad level, it's important to know CBT is used for basically everything. Depression, anxiety, insomnia. It's used for things like hypertension. It's used for even things like bipolar disorder and schizophrenia. There are forms of CBT that work. So it's essentially teaching people a set of skills to manage stress, to manage strong emotions and negative cognitions, while bolstering more adaptive or healthy coping. So in the area of chronic pain, CBT is the gold standard. It's the one is the most common. It's been validated in basically every pain condition under the sun, everything from chronic low back pain to post-herpetic neuralgia and post-burn pain. So it has an effect on coping variables like catastrophizing. It improves mood, and it does improve disability, sort of a small to moderate degree. There is a freestanding small effect on pain intensity. And by the way, when I use these terms, what that refers to is across large-scale studies, there is an average effect that is small. So about a half a point to a point on the 0 to 10 scale. So the thing that's important to know is that in some cases, it can be much larger than that, and some people report no benefit at all. So the nice thing about CBT is that it's pretty appetitive. It's pretty easy to explain to patients how you would use it. They don't usually reject the premise of learning other ways to manage pain, and it can be used in a class format pretty easily. So the way we pitch it, like I said, is a toolbox. So this involves behavioral skills, things like relaxation, planning physical activity, and how to communicate about pain. Because one of the common refrains we hear from people with chronic pain of all ages is people don't get it. They look at me and they think I'm healthy, but my body is screaming at me. And so it's really hard for people to understand what I'm going through. And that can fuel the problems with depression or anxiety or isolation. Why would I bother to spend time with people if nobody gets what I'm going through? And I always walk away feeling like nobody's getting it. Things like behavioral activation. When I use behavioral activation here, this is the idea that one of the best treatments we have incidentally for something like depression is to get people up and moving, and ideally to get them doing something enjoyable or socially connected. So this works regardless of the group. It's probably, I've been calling it caveman psychology. It doesn't involve any fancy technology. The more you can get your brain and body to move, the better off you are. It has a specific effect here. And by the way, most of the effects we see for CBT seem to be driven by how activated we can get our patients. We also work on things like sleep improvement, which is a common problem in chronic pain. If it hurts to lay down and it hurts to move and it hurts to stay still, it's going to be hard for me to sleep, especially if I'm not as physically active. I don't have a normal routine. And then we work as well on things like how to deal with negative thoughts that may come up. So how to view them in a little bit less of a damaging or negative way. For anybody who's curious, this is the sort of work we do on the cognitive behavioral, the cognitive piece. So the idea here that we can sort of walk people through the idea that your thoughts come up as a predictable response to the situation that you're in. So where were you? I woke up and my pain was greater than it normally was. What emotion did I feel? Well, I felt frustrated. What was the first thought that came up? Oh crap, not this again. My body is falling apart. Well, how did that make you feel? I felt frustrated. What is the evidence that supports this? What's the evidence against this? And what you're trying to do really is get people to argue against these thoughts when they come up. Not with the idea that you're going to wholesale change their pattern of thinking, but just so you can get them unstuck in that moment so they can go back to what they should be doing that's going to make them healthier. So instead of having the thought, why bother? None of this is going to work, and then going back to bed, you can say, all right, my brain's just doing that thing that I don't like. It's telling me how bad things are. I'm still going to get up and go to work today. I'm still going to go to the gym. And so what we look for here, I don't love the term alternative thoughts. That now, I guess, has maybe a slightly political meaning. But the idea here is that we have a replacement thought that is maybe less negative, that helps people move through a frustrating or negative experience. And at the end, they should feel less of whatever the emotion is that is getting in their way. And incidentally, there's a lot of these things for free online. I'm not actually sure the one from Psychology Tools is free anymore, but you can find a lot of these sort of thought records very easily through Google. So the way that CBT for pain works, it reduces that sort of fear or catastrophic view of pain. So by teaching people ways to manage it, it starts to give them a better sense of control. Even though I may not be able to make my pain go away, it does not have to be a catastrophe. It does not have to be a disaster. It helps them be more active in ways that are otherwise healthy, things like exercise. It reduces the reliance on medications as the only or the first response when people have more pain. And in the context of the opioid crisis, we're finding this increasingly important. And then in general, we're trying to get people to be less avoidant. So if I can learn ways to manage pain, that means the next time I have a pain flare, I don't have to wipe out my schedule for the next 5 days. I have a set of skills, I know what to do, and I can keep going. So pain self-management there's actually been a pretty strong body of evidence for this across medical conditions. Historically, this was done a lot by a group at Stanford. They did, Kate Lorig's group did a lot of this in things like chronic disease management and diabetes. And there's a form for arthritis. There's a form that's sort of been used for chronic pain as well. And it's largely based on CBT. It often involves exercise as well. And it shows kind of similar effects on pain and disability. But again, the duration of how long these effects last is unclear. The really unique thing about pain self-management is that it does not require a psychologist to deliver it. This can be done using both lay people and then maybe those that are a little bit less specialized. So we'll talk a little bit later. I have some resources for how to find these resources, but typically it's a weekly class for an hour or 2 hours. You teach people things like what pain is. And by the way, the one in older adults that has the strongest effect is arthritis, which is a common complaint and a nice place to start. It does tend to be more cost effective, especially when you're talking about people being able to access this at the community level rather than having to go to a tertiary care pain clinic or a big hospital. So when and if these things are available, they're a nice thing to access for patients. And the other benefit to something like this is because it's often facilitated by somebody who is not a doctor, you can actually it often has a little bit more credibility coming in. So the person teaching the classes is often somebody who's already been through it and has had pain and can speak to how well it works. But like I said, the evidence here is not quite as strong as it is for some of the other interventions, but it's a nice low-cost option when and if you find it available. So another one that's been pretty popular actually since the early 1980s is mindfulness-based stress reduction. And there are other forms of mindfulness meditation as well that have been used. But it's essentially based on Buddhist and yogic practices. It conceptualizes pain as an alarm signal. So it's happening because there's an alarm signal that's occurring for some reason. And what that does is it triggers a series of automatic responses. I go into autopilot and I start doing things that don't help me very much. So I freeze up, I get anxious, I get angry, I snap at people, I withdraw. And what we're trying to do with a meditation approach is to help people sort of bring themselves back to the present, regulate whatever stress or strong emotions are there, sit with them without trying to fight them, and then to make a response that is maybe a little bit more adaptive. So you can see that they use lots of heavy words like detached self-observation. The basic idea here is we're teaching people to sit calmly with whatever is happening around them, and then to make a decision once they've sort of ridden through the storm. This is, again, often taught in a class format. It starts with basic meditation training, things like a mindful breathing exercise. They go through how to pay attention to different parts of your body without responding negatively or just sort of checking in calmly. Mindful yoga, so gentle movement and how to pay attention to that. How to use meditation to manage stress in everyday life, working through stress and illness, communication, and then things that maybe are, there's almost sort of a bolstering of enjoyment. So they have people do mindful eating and mindful walking. And so this is the idea that we can sort of mindfully be aware of normal things we do in day-to-day life that enrich their value. And in the long run, there's actually pretty good effects as far as things like reducing stress and improving quality of life. So one of the things about MBSR is that it does tend to be a little bit more involved. People who go through these classes are kind of required or very strongly encouraged to do a daily meditation practice. And for some of our patients whose lives may be a little more chaotic, that may or may not be feasible. It does have a pretty strong body of evidence. So it reduces sort of these unhealthy reactions to pain. It helps people feel like they can stay in the present more effectively. They get less stressed. As with and most other treatments, people view pain as less catastrophic after they go through classes like this. They feel more accepting or more flexible in response to pain. And then it's this sort of idea that you're teaching people a mindful lifestyle. You're not giving them a toolbox. You're teaching them how to approach their entire lives in a more sort of calm or present focused way. So sort of a fusion of the last two approaches is called acceptance and commitment therapy, which incidentally has a terrible name and patients hate it. They do not like being told to accept things. And so they've actually rebranded it. You can see at the bottom, it's now called contextual CBT because of course it is. The focus here is on teaching people, rather than trying to control their thoughts, it's focusing on changing their responses to their thoughts and motivating people to act in ways that are in accordance with their own personal values. So the idea is my brain may keep telling me, no matter how much I try, that if I go to the gym, it's going to hurt me. But my values say, if I want to stay healthy, this is the right thing to do. So the model and ACT suggests that you are going to recognize those thoughts, and rather than get stuck in them and fight them and spend all of your time writing out long thought logs, you can sort of recognize that that's what's happening and then step back from it and make the choice that in the moment makes the most sense for you. And so the focus here, instead of pain relief, is meaningful function. So you're teaching people to orient away from, is this going to hurt me? And more, is it worth it for me? So people do not like the label, but once people get into something like ACT, a lot of them end up walking out feeling like, we like this. We even have a form that's being done by my colleague in psychiatry. People love talking about their personal values. They love talking about what's important to them. And the thing about chronic pain is often people sort of feel like I've been pushed away from that. This isn't the life I thought I was going to live. We even hear pain has changed who I am. And that's a really, really painful thing to admit. So the idea here is, well, we can sort of bring you back to paying attention to what is important to you. You haven't stopped being who you are, but what you have had is you've fallen into some of these common traps about pulling away from what's important just as a means of sort of we're sacrificing the long term for the short term. It may be easier for me to skip exercise every day than to commit to it even if it's painful. So this is called the the ACT hexaflex. For obvious reasons, I won't bother to dwell on that. These are the sort of core tenets of acceptance commitment therapy. So being present, bringing people back to the present moment, accepting whatever sensations or thoughts or emotions they have, being able to recognize those sensations as things that happen to me rather than a reflection of reality. That's diffusion. And then the sort of remaining three self and context values and committed action are the idea that I'm going to orient away from however I feel in this moment and towards what do I want for myself. So who do I want to be? Do I want to be, so is it more important for me to avoid this pain right now, or is it better for me to be an effective parent? And so you work with people sort of gradually on things like exploring the difference between short-term and long-term benefits of however you're coping. So you've relied purely on medications for your pain management. How well has that worked for you so far? Has that gotten you what you wanted? You know, you've pulled away from all of your relationships. Do you feel like that's worked well for you? And by the way, it'll be less judgy than the way I just said it. Then we work a little bit more on mindfulness and how that relates to behavior change. So how your thoughts and pain and emotions and behaviors are all tied together. And once one starts, it can sort of start a cascade among all the others. The idea of acceptance. By the way, when we use the term acceptance, we don't mean resigning yourself to having pain forever. Acceptance here is defined as there are certain experiences I'm gonna have no matter what I do, and trying to fight them only makes them worse. We used to use the term, we talk about the finger traps, Chinese finger trap, the harder I pull, the tighter it gets. So if I try and force myself not to think something or not to feel a certain way, I usually just end up reinforcing that thing, and pain works that way. So if I try and avoid pain at all costs, I'm not gonna end up with less pain, I'm probably gonna end up with more pain, because now there's nothing else in my life that's going for me. So the focus is, again, going from what maybe I've used to help me avoid, and instead focusing a little bit more on what's meaningful. Goals versus values. This is one I like to do with my patients a lot. The difference between a goal and a value. A goal is a thing you put on a list and check off. Value is usually the thing behind it that is the grander goal that you're not ever going to fully check off. So if my value is that I want to be a good person, I don't do that once and check it off the list and say, boom, I'm done. I never have to be a good person again. But from my values, from that value, I might decide, for example, to work at a soup kitchen. I might decide to donate my time or my money towards something. I might choose to help somebody that I know who's distressed. So values inform our healthiest goals. And then we work on things like how to break some of these automatic negative processes that happen. So one of the common things we hear in chronic pain is that people who are trying really hard to manage it is that they push really hard, they flare, and then they knock themselves out for a period of days afterwards. So instead of gritting your teeth and trying to ignore it and push that pain away, we sort of start to listen to it and more gently introduce things like physical activity, which incidentally is something that's done in CBT as well. And then working with what to do when it's not clear what the right step is, what to do when it feels like, you know, my thoughts are telling me to do one thing and my values are telling me to do another. And then, yeah, so this is kind of a broad synopsis for what we're talking about for ACT here. So much like the other interventions, ACT has a pretty strong body of evidence, but it's smaller. ACT has sort of only has come in vogue in the last 20, 25 years or so. One of the key differences between ACT and MBSR is that it doesn't really require daily meditation. You're not having people go through a daily meditation practice and then like a full day or a half day meditation retreat, but they do still use it. And it works kind of similarly as you're seeing with the other interventions, things like mood, disability, function, and then smaller effects for things like pain and depression. So by and large, these seem to be functioning, and it's probably not surprising given that these therapeutic approaches are not totally distinct, that they all sort of bleed into one another, especially if you're doing this work a lot. But it does work. And one that's done, it's maybe a little less in vogue now, but can still work, is sort of a combination of psychology and physical therapy. This is the idea that you can slowly introduce people to activities that they might find painful or that they're really afraid of. And in doing so, you can actually reduce fear and help them do those activities safely and with a higher tolerance. So what this may involve is, for example, somebody who's really afraid, who's got really severe back pain and a lot of fear around their pain, kind of building a hierarchy. So from 0 to 10, what are the activities we can do that are maybe mildly fearful for you, all the way up to the ones that you're most terrified of. So everything from a slight bend forward to being able to lift a box over my head. And you work slowly with them on ways of managing the stress or emotions that come up with that, while helping them slowly make that progress upwards. And again, the model here really suggests that it's not really about damage in the body. It's really more about helping recondition the body and helping the brain tolerate whatever is happening. So one of the things that I'm going to tie back to over and over again is that with chronic pain, you can pretty confidently say to somebody, your brain is distressed. It is trying to protect you in a way that probably isn't as helpful as you'd want it to be. It doesn't mean there's nothing going on in your body, but it means that we have to work on the brain also. And so this approach is something, this graded exposure approach is the same thing they use for things like phobia. If you're afraid of heights, we don't take you into a plane and throw you out. We have to work our way up to something like that. So you might start with a slight graded increase. You're standing at a slightly higher level than you're comfortable with until you get used to that, and then you gradually work your way up. So much like the other things, and I think you can see in certain conditions, this is a little bit more promising, probably because it involves a sort of a combined approach using two professionals, but it reduces pain and it reduces disability, it reduces fear and catastrophizing, and it reduces anxiety and depression. But it's primarily studied in musculoskeletal pains, primarily low back pain. It does have some evidence in other chronic pain conditions, things like whiplash and complex regional pain syndrome. But by and large, it does seem to be this reduced fear and harmfulness of activity, and that's really what's allowing people to get better. So it's sort of a similar mechanism as the other interventions. So actually here at UW, we have one of the biggest groups that's in the world on clinical hypnosis for chronic pain. This is at Harborview. So what this has historically been is, so everybody's got sort of what we might consider a flawed understanding of what hypnosis is. This is not the stage hypnosis where you bring somebody on stage and make them cluck like a chicken. This is a lot more of a collaborative process where you educate people about how, if you can get your brain into a more suggestive state, you can give them, usually through something like deep relaxation. And it's, by the way, a purely collaborative process. This is never done coercively. This is always done in concert with what the patient wants. So you deepen them into this relaxed state. You give them some suggestions about maybe ways that pain could be less threatening. So things like, now that you're in this sort of safe, calm place that you've created for yourself, maybe you can move your pain around, or maybe you can pay attention to it and have it be less threatening. Maybe you can even notice that it shrinks, or that it feels less intense, or that if it's sharp, it starts to dull, or that you can feel relaxed, or that you'll be able to sleep better, even if the pain is there. And then you kind of bring them back out. And across time, a lot of the clinical hypnosis research suggests two things. First, you can actually teach a fair number of people to do self-hypnosis. So it's probably as much about teaching them that they can manage these processes themselves, but it also seems to enhance other forms of psychotherapy. So the group here at Harborview has talked about how to enhance something like CBT using hypnosis. And so what the research seems to show, and again, it's really a few sites that do most of this research, but about 70% of patients report some degree of pain reduction, like in the session or immediately afterwards. And then there's a subset where they actually, 20 to 30% who report some degree of long-term relief from doing this. I've had patients who learned clinical hypnosis in the 80s, and they say, I can still use some of that, and it still helps. So it's not everybody, but it's one more tool in the toolbox. And so, like I said, it's always a voluntary process, and it can be taught as self-hypnosis. There is a subset of patients who are not hypnotizable. We don't totally understand that, but it's one more thing to try. And if you've got providers out in the community that are well-trained, this can be a nice option for patients that are, especially those that are a little more open to this sort of biopsychosocial model for pain management. This is my most text-heavy slide. I apologize for that. This is simultaneously one of the newer areas and one of the oldest areas in psychology and how in chronic pain. And it's this idea, especially for our patients with a trauma history. So we know that there's a huge degree of comorbidity between chronic pain and PTSD. The estimates range pretty wildly, but it's probably 30 to 40% of our patients with chronic pain. In the pain clinic, it's about a third of our patients with chronic pain also have PTSD. And so that is a much higher prevalence than it is in the general population. So we know trauma and PTSD actually seem to fuel this chronic pain circuit. Now, there's some neuroscience evidence that suggests maybe why that is, that it's the same threat circuit that's active from trauma and chronic pain. But either way, what we're seeing is that for a lot of patients, there's some commonalities where they kind of come in and they're really avoidant about the things that where they had the trauma before. And if you can help them sort of express, to talk about the trauma, to process what happened, and to work around the emotions that are there, it can have a pretty strong effect on pain and mood. Now, again, this is a much smaller body of evidence in the sense that it's actually been clinically validated, more so in the last 10 years. And it primarily seems to work in centralized forms of pain. When I say centralized forms of pain, this is things like fibromyalgia and chronic migraines and IBS. And so there's something about these models where, and I kind of glossed over this in an earlier slide, but the basic idea is you can get chronic pain that it kind of occurs independent of anything that's happening structurally in the body that we can see. Fibromyalgia is the clearest example of that. And it does seem to be sort of a brain and nervous system derived problem. So this is an area that it's pretty hard to find providers because, like I said, the treatment's only really been validated for the last few years. But it can be pretty powerful for those that come in with a lot of pain, a lot of strong emotion, and a lot of sort of pain symptoms that may not track as clearly with the sort of structural problems that you're seeing. It's not real clear how to use this with people with really active psychiatric conditions. If they're severely depressed or have really severe PTSD, there's probably still a role to get that stabilized before you were to go through something like this. But all of that right now is conjecture. So to summarize the literature, and I kind of been talking about this already, CBT has the strongest research support overall in the sense that it's been validated in basically everything. With few exceptions, it seems to work about the same regardless of the pain condition. It works really well for those with high fear of pain, those that aren't sleeping well, or those that you might see that you feel like they probably could use some other ways of coping with stress. For those that are maybe a little more inflexible, or those who kind of think that they're going to be fixed by coming in to see you, they may not be the best candidates for CBT, because asking them, CBT is heavily self-management based. You're asking people to go out and do things that you're teaching them in session. And if they're not at that point, you may not make it very far. For those that are really afraid that they're going to harm themselves, they really need a lot of reassurance, these sort of graded exposure approaches can work out nicely. And whenever you can find a provider that provides some hypnosis and you've got patients that are open to it, it's again it can be a pretty powerful effect that enhances whatever else they're doing. The sort of mindfulness-based therapies, and that includes ACT and the mindfulness-based stress reduction here, it does seem to work a little bit better for patients with at least a moderate degree of psychological distress, or those that are maybe not as, that they have the benefit here of being a little bit less directive. Some of our patients don't like the idea of you're going to bring them in and tell them how to live their lives. So these are a little bit more flexible. This is about teaching people to sort of be present in the moment. It frees them to do what they would otherwise be doing that's healthy for them. So it's a nice selling point. And really, the two treatments, MBSR and ACT, are not that different. They sort of orient things a little bit differently. MBSR is a little more structured, but in general, what you're sort of fostering for people is this idea that you can stay calm in the face of something really threatening or really painful or really stressful, and then to make a better choice that will actually make you healthier in the long run. And it doesn't actually have to diminish your enjoyment of what's happening right now. So acceptance is a four-letter word to a lot of our patients, like I alluded to earlier, but it sort of has this mechanism where people start to become a little more accepting of whatever is happening for them. And that's sort of a place we want them to be for self-management purposes. So that was my long psychology piece. We'll tie a little bit more back to the audience here. So some special considerations for pain management in psych in older adults. So like I said, the research base is smaller, but it shows some degree of benefit. It shows essentially the same degree of benefit for older adults. And historically, there's been this idea that maybe older adults aren't going to be as interested in psychological approaches. And actually, to date, all the research that they've done on levels of acceptability, older adults do just fine with these. They're not any less willing to try out psychological approaches than younger adults. And so this may have just been a misconception that we sort of inadvertently pushed along for a long time. There is a little bit of research saying that, you know, some older adults are a little more skeptical of how are you going to change my thinking pattern that's going to change my pain. So the truth is, actually, the broader research literature tells us it's behavior that matters the most in most cases anyway. So if you can kind of tie it a little bit more to teaching them to act in ways that are better for their pain rehab, it works a little bit better. And so this idea of teaching them skills in a toolbox is a pretty nice selling point. So one of the things that I alluded to earlier, clarifying for our patients, just because you're getting older does not mean that you're supposed to have pain. That is a misconception. One of the things that can be really problematic is that they start to assume I'm just supposed to have this, that if that's never addressed, that may actually just lead them to deteriorate in the longer term. So we want to emphasize for people that even in older adults, when you have pain, it's not because you're old, it's because you have an illness or an injury and it needs to be treated. So one of the things that comes up a lot, and actually my colleague in the anesthesia realm, Kushang Patel, is doing a clinical intervention on this study on this right now, is fear of falling. In older adults, this is a big concern, the idea that I'm going to fall, I'm going to injure myself, and it's going to cause a problem. Now the challenge is, like we were talking about with that fear avoidance model, when adults are afraid they're going to fall, what are they likely to do? They're likely to stop moving. They're going to stop walking. They're going to stop doing those things that otherwise make them healthy. And then what happens? They get deconditioned, their balance gets worse, and then they actually fall more. So there's sort of a fine line we have to walk with this, where we're emphasizing, yes, we want to, of course, reduce risk, and we want to make sure that if you fall the right way. And some of our participants in this study actually told us, I've been taught how to fall, right? I can fall in ways that will damage me less. I don't fall wrists down. I can turn and roll. We had a participant who was very proud of that told us that last week. And so while still telling them you need to be active, otherwise this is likely to get worse. So you can move and be safe and be healthy and still manage the risk of falling. And I want to make special note of chronic pain and dementia. Unfortunately, even in the area of older adults in chronic pain where pain is already underassessed, it's even worse in dementia. And this is for the reasons you might expect. For adults who are not really able, cognitively intact, they're not able to communicate about what's happening to them as effectively, this is more likely to get missed. But the nice thing is there is actually some research that shows, especially when it's done in sort of a supportive manner or in a social setting, you can actually teach people some of the same strategies, things like deep breathing or muscle relaxation. And it can have an effect on pain for them, just like it does in older adults that don't have any sort of cognitive impairment. But even here, there's a pretty small body of research. So when and if it's possible, it's something to keep an eye out for. So the considerations for primary care. One of the things we love to have our providers do is to encourage patients through gradual behavior change to manage their own disease. This is what increases the likelihood that they will actually be better off in the long run rather than worse. So telling patients, there's a lot of ways to facilitate your pain improvement. And that might involve things like managing your stress level, changing your diet, learning to be more physically active, improving your sleep. And incidentally, I would say just anecdotally, one of the things my patients love to talk about when it's a problem is sleep. If you can work on that with them, they usually end up coming in feeling better. And if, it turns out it is pretty hard to start an exercise plan if you're sleep deprived. Now, the irony is if you exercise more, it actually gets easier to sleep. So you can see everything sort of runs in circles with chronic pain management. But what we often encourage providers to do is to help patients make these changes gradually. Do not try and make 5 new changes. You're likely to flame out and you're not likely to get any benefit from it. You can now look at it as, well, that was another failure that I just had. So if you're going to see patients, and the nice thing about primary care is that you have the ability to see them on a more regular basis here, having them start with one thing. So when we do this in our telepain meetings, which are for primary care providers in the community for chronic pain, we have them have patients start a walking plan, or a sit and be fit plan, or a gentle yoga plan. And that's the one thing they're asked to do first. It's not about doing that and going to find a psychologist and all these other things that may not be possible or may not be feasible when people are already dealing with a lot of pain, a lot of fatigue, and a lot of mood problems. So making these changes gradually matters a lot. And whenever you can, regardless of the sort of degree of mental health services, look, specialty pain psychology services are rare. As far as I understand it, there's only a handful of pain psychologists in a city like Seattle. So when you get further out, they're even rarer. But that doesn't mean that other mental health resources can't be used. This can include things like social workers, many of whom have great training in this, especially when it comes to things like mood management, stress management, sleep improvement. And in less populous areas, this may include things like counseling students. If you've got smaller areas with schools that have trainees, it's another option, especially for patients that maybe are low income. And they can be effective. What you're still teaching here, the broad model here, is that there's something that patients can do to manage their condition. So I mentioned this earlier, and because I'm a psychologist, I repeat everything to everybody all the time. This is one of the things I want to emphasize the most. Whenever possible, encourage your patients and reassure them that movement is safe. Our patients surprise me often, how often they come in saying, I actually don't know that I can do this without damaging my body. And when I ask them, did you talk to your doctor? They sort of shrug at me. Well, if you didn't tell them, how did you get to me? Didn't somebody tell you that it was okay to move? But the thing is, sometimes they are told to move, but they're not told you can do this without damaging yourself. And that is a key consideration. And patients do not get that, which is why the discussion about acute versus chronic pain is a nice thing to introduce if you're not already doing it. And for our more motivated patients, which are obviously not the ones we're most worried about, but it's still a group we want to treat, there are a lot of phone apps and self-management books that I'll actually emphasize in a couple of slides. And so it's the same idea here. There's things you can do about this. I even have had a handful of patients who take the sleep improvement book that I recommend. They come in 4 weeks later and they say, actually, I'm sleeping pretty well now. Now, it'd be nice if everybody did that. But I guess if everybody did that, I wouldn't have a job. So we'll balance that. But it's nice to have as many options as possible. So educating patients about chronic pain, this is a little bit repetitive, so forgive me on that. Good pain treatment requires multiple approaches. If you're expecting your medications or your injections to fix your chronic pain, you're probably going to be waiting a while. So it involves not just medicine, but also exercise or movement, some sort of mind-body therapy, and it doesn't have to involve seeing a psychologist. There's a lot of providers that can provide this. And then complementary treatments like yoga, Tai Chi, acupuncture as well. All pain has a psychological component, regardless of whether it's acute or chronic, regardless of the patient. That is just part of the hard-coded signal of what chronic pain is. So seeing a mental health provider doesn't mean that their pain is not real. And one of the fears that patients sometimes have is, if I see a mental health provider, that means my doctor is going to stop treating me medically. So it's a useful conversation to have with them to say, no, this is supplementing your treatment. We are not replacing one with the other. I'm not in the dumping ground of psychology because medicine has failed me. And so what I often told patients is, if you want to know where your physical pain connects to your psychological pain, it's your brain, it's your nervous system. The two reside in the same location. And so if you really want your pain to get better, you have to treat both. And whenever possible, we want to emphasize that function and quality of life come first. Pain is usually not the point. As bad as it feels, everybody was a person before they had chronic pain. And that's what we want them to get back to. So put a little plug here at the end. So this pain is a lagging indicator. My colleague, Mark Sullivan, and I are writing a paper right now, or have one under review right now, is pain is the last thing to get better when you're treating people in a multidisciplinary setting. Their sleep, their mood, their function, all those things get better first, and then pain does. And so that's the model we want to pitch to patients. Even if we can't force the pain to go down right away, and we would love to, this is still an option. There are still things you can do that improve your quality of life, and in the long run, they actually can help you get better. So I think everybody gets these slides. These are just some options. So these are searchable options through the CDC for self-management programs. There's a mindfulness class finder through the University of Massachusetts Medical School website. They're the ones that developed MBSR. For those looking for exercise resources for seniors, the silver sneakers are a nice option, especially in big city settings. Sit and Be Fit can be found. There's actually a lot of free resources and low-cost resources on there. And you can find a lot of gentle yoga videos actually on YouTube as well. Finding psychological providers for chronic pain is tough, but the best place to go is usually the Psychology Today website. They have a therapist search function that's searchable by zip code, by insurance, by clinical competency. It's probably the best catchment as far as getting people who at least do some of this work. It turns out you don't actually have to have a lot of formal training to claim to do it. So buyer beware, but it's better than nothing. And usually state psychological associations also have a similar searchable function. And sometimes, but not always, they vet that a little bit more. So these are options if you're looking for mental health services for your patients. As far as patient education, the American Chronic Pain Association has a bunch of really nice free resources. They're sort of more patient advocacy based, but they do a lot of work on things like educating people about what pain is and how to effectively manage it and how to live with it. You can find some CBT handouts at the Psychology Tools website, but like I said, I don't think that's free anymore. That's why it was initially on this slide. And there's a whole bunch of books I recommend for people. The ones that I will highlight here, for those that are really struggling with sleep, Quiet Your Mind and Get to Sleep is a great option. It's written by a couple of sleep experts, one from Stanford, and it's sort of a how-to book on how to improve insomnia if you have depression, anxiety, or chronic pain. The Feeling Good Handbook is the only self-help book that in existence, at least as far as I know, that actually has research evidence behind it. So it works for depression. Managing Pain Before It Manages You is a field standard for CBT for pain. It's another how-to book. It's something patients can read and learn how to do these things on their own. And then there's some phone apps that I recommend here as well. Insight Timer is a little bit more variable, but it's a meditation-based app and it's free of charge. So it's a nice one to check out. I think they do have a proprietary section as well. And then there are some other proprietary ones. Calm and Headspace are really relaxation and meditation focused. And there's one that's sort of a fusion of the two that works a little bit more on emotions and trauma and things like that called Curable. But again, it's proprietary as well. And so that one, your results may vary depending on how much patients are willing to spend on it. All right. So that was my talk. I think I went a little under. Hope that was okay.
So I actually already have a question, and this is someone who has asked, how do you stop the pain of a migraine using the fear avoidance model?
How do you stop well, the thing with migraines is that they're a little bit different. So unlike something like back pain where you may be able to sit down and sort of immediately resolve it, migraines sometimes kind of take you on that, you're on that wave and you have to sort of ride that wave till the very end. But the avoidance model still applies here in the sense that people can start to learn, well, certain things are likely to give me a headache, but by avoiding them, they actually make them worse. My classic example here is, a classic migraine trigger is bright light, right? So when you ever seen a patient who wears dark sunglasses indoors? We see them all the time. And so the challenge with that is by avoiding light, you're sensitizing yourself to it. And this is, by the way, a normative thing. Anybody here walk out of a movie theater in that first few minutes, it's hard to tolerate light? Now imagine if you were already sensitive to light and you hadn't seen light in 2 months. So the same model applies here, which is if I avoid this too much, I'm actually going to end up sensitized to it. It doesn't mean I should go out and stick my head in a floodlight to fix it, but that I have to slowly work myself back in to those things that I'm sensitive to. But what that really involves is first helping patients to understand what their triggers are. So if I have no idea, it's really hard to do an exposure plan or to work their way back in. But if it's stress, you work on a stress management plan. If it's bright lights or loud noise or food triggers, you can work on those things a little bit differently. But avoidance can sensitize, I guess is the takeaway there.
Do you have any questions in the room?
Stunned silence, that's what I
Well,
want.
I have another one here. Does Medicare pay for CBT or other alternate pain management?
It often does, yes. Now, I can only speak to Washington, but a fair number of my patients here have Medicare, and they do seem to get it covered, yes. It's got a strong body of evidence, and there's a lot of even free research articles you can find that support its efficacy. I wrote one actually a few years ago that you can find for free online. It's not hard to get justification for why you would do this in addition to whatever you're already doing medically.
That's good to know. So this is $1 million question. Is it beneficial to keep a person on opioids for pain control if they don't have euphoria?
Oh boy, I am probably the wrong professional to answer that. My feeling as a non-prescriber, as a non-physician, is it's always a process of risk mitigation whenever we can. And since we're talking about opioids, the truth is, in the long run, there is very little evidence that keeping people on opioids improves pain or function in the long term. And it may actually increase their likelihood of other problems. Like in males, hypogonadism, we get low testosterone. There can be problems with worsened depression. It can actually cause other medical comorbidities that are a risk. Now, if they're within that sort of CDC range, which I guess maybe is applicable, I don't know. The truth is, even my colleagues that are medical providers are a little skeptical of that, but it's a nice framework to operate from. I would work with patients. My goal whenever I see a patient is to make it so that whatever medications they're taking become less necessary in the long run. I think that it's usually a win if you can get them to the point where they need fewer opioids because they are risky. There's no really two ways about that. So I would say that you want to sort of tread carefully with opioid prescribing because both from a clinical and a broader governmental regulatory standpoint, the solid ground for opioid prescribing is sort of shrinking a little bit. We don't want to subject our providers or our patients to that sort of scrutiny in the future.
And you have or haven't found the euphoric effects to be diagnostic?
Not really. Now there is some, it's been suggested by some people, by some providers that, you know, what you're really doing sometimes when you treat pain, chronic pain using opioids, is that you may also be treating stress or a mental health condition. And so this is especially true for our patients that are on both opioids and benzodiazepines, or opioids and Z drugs, like the sleep drugs. So I would say tread carefully. There's probably a role for opioids in some form of pain management, but they should be used conservatively. That's kind of what the whole field is moving towards. So as far as the euphoria, the truth is that they can be sort of problematic because, especially when you use these things chronically, the effects change. That's kind of one of the biggest problems in opioids, is that you don't get that same degree of pain relief the first time, the 200th time you take the pill as you did the first time. And so as a non-prescriber, I don't have to worry so much about the euphoria. By the time they come to me, it's already been sort of beaten into their heads that they have to self-manage. But I would say tread carefully there and understand that even if patients are using medications exactly as they're supposed to, that doesn't mean that you've eliminated all risk. So, you know, at the end of the day, we sometimes have to go to the bottom of the toolbox to help people get better, and that's fine, but understand that that's kind of what the evidence is telling us about opioids, that they should be at the bottom of the toolbox, not at the top.
So here's a question. I think it's referring to sort of pain management visits that you might do. What is the duration of your visit, and how often do you schedule the visits?
So the ideal, which doesn't happen that much anymore, to be honest, I see people usually, for something like CBT, it's 4 to 8 sessions. It can be longer, but you know, if you can sort of drill down to a set of skills that are pretty easy to implement there. And
how long is the session?
45 to 60 minutes. But again, like I said, in primary care, you may not have the setup to have your psychologist see people 4 to 6 times, but not everybody needs 4 to 6 times either. And so there are ways of implementing some of these skills in a freestanding way that can have a benefit. So unfortunately, the research hasn't really caught up to that yet. Brief interventions, while studied, they're not as popular to study, and they don't show the same degree of effect, but they can be effective because there are some patients that are pretty close. They're already pretty close to self-managing. They just need a few more skills. So it's a nice option there as well. And just like I mentioned in psychology and primary care, it's sort of a stepped approach. Some of our patients that come in and they're doing okay, and you don't really worry about their safety, and but they need to exercise a little bit more. You can teach them how to pace and how to breathe and things like that, and then they're kind of done. They can go back to whatever they're doing. So think of it as sort of a flexible model whenever you can implement it.
We'll have one more thing in the chat box that just says, "This has been great."
Oh, good. I'm glad to hear that. All right. Thank you guys for lasting at 5:30 in the afternoon. Appreciate that.